Okay.
Yep. the proceedings here underway. My name's Shuli Ghosh. I'm going to be your host for the next hour or so. Goodness, that's nice and loud, isn't it? I don't have to project so much. Yes, I'll be your host for the next hour or so for this session. Just a couple of housekeeping notices. There are headphones on the desk over there. They're in two bits. You've got the headphone and you've got the little black handheld thing. Plug one into another and you will have translation. The channels are, one is English, 2 is Spanish, 3 is French. So if you need translation, and part of the proceedings will be in Spanish, so do grab yourself a pair of the headphones if you need a translation. And secondly, very pleased to say that the whole of this session is going to be streamed via webcam on the IFPMA website. The link is going to be tweeted, so that means everyone outside of this room can also look at this throughout the WHA. So today, here's what we're going to do. We're going to be discussing how public and private partners are coming together to accomplish the very ambitious target set by the Sustainable Development Goals. That is reducing premature deaths from NCDs, non-communicable diseases, by a third by the year 2030. As you're probably aware, NCDs, diseases like cardiovascular disease, cancers, respiratory diseases, diabetes, these are a huge burden on the world. Something like 40 million deaths caused by NCDs every year. And that, of course, is placing an extraordinary toll, a huge burden on people, particularly in the low to low middle income countries. Something like 80%, the vast majority of premature deaths occurring in those countries. The economic burden of this is vast. In fact, recent estimates say that over the next 20 years, the cost to the global economy of NCDs is going to be in the region of 47 trillion US dollars. It's a huge burden. So clearly, it's a massive challenge, and we've got to find ways of dealing with this, new solutions, and ways of working together, and that's what we're going to be talking about here today. So we're going to have 3 panels. We're going to be discussing the challenges, and we're also going to be discussing the role of the private sector and how an industry initiative, Access Accelerated, has been put together to address the many barriers that we're seeing in low and lower middle income countries in terms of access to NCD care and NCD medicines. Access Accelerated involves 23 biopharmaceutical companies and partners, including the World Bank and the Union for International Cancer. We'll be hearing from them. And they're working towards the SDG of reducing NCD deaths by a third in the next 13 years. So we're going to be looking at a city cancer initiative in Asunción in Paraguay. Then we're going to talk with the World Bank. We'll learn more about a series of countrywide pilots which are being planned for several cities worldwide. And finally, we're going to take a look at the whole issue of public-private partnerships. What are the challenges there? How do we make sure that we have partnerships which are successful and which have the most impact? So we're going to be doing 3 what we call lightning discussions, okay, 20 minutes each. I'm going to be grilling these lovely people on the front row here for about 10 minutes, and then it's going to be your turn. We're going to have questions from the floor. There are a couple of microphones that are going to be doing the rounds, and I really want to hear from as many of you as possible, because this is your chance to put your queries. I would ask that you keep your questions short and to the point so we can get through as many as possible, because we've got 3 sessions to fit in the next hour. So when that happens, look out for the microphones and grab one of those. Okay, so let's get started. Our first session today is looking at the CCAN 2025 City Cancer Challenge, with the spotlight on one of the first what we call learning cities, which is Asunción in Paraguay. So I'm going to invite to the stage our first panelists, the first secretary of the UN's Permanent Mission to Paraguay, Miguel Candia, and the CEO of the UICC, Kerry Adams. To the floor, please.
Thank you.
Gentlemen, welcome to to the panel. Now, you're going to be grilled by the audience in just a minute, but I'm going to start off. I'm going to start with you, Kerry, because the City Cancer Challenge is eventually going to target 200 cities worldwide. So let's start with the obvious question. Why cities?
Well, when we look at the challenge that we face in cancer and the other NCDs over the next 20, 30 years, we concluded that if we were able to work with cities around the world where currently you have half the world's population growing to nearly 2/3 of the world's population in that period through to 2050, it would make sense to put in place a health infrastructure which is where the growth and where the burden is occurring. So in discussion with a lot of our partners, many of them are in here, including Access Accelerated, the radiotherapy industry, members of UICC and our colleagues at the NCD Alliance, we concluded to create a global initiative which could bring true partnership together with a very focused attention on helping cities like Asunción understand the nature of the burden they're facing in the future, and then bring that collaborative expertise, support, energy and resource to assist them to address the future burden of cancer.
We know that Paraguay already has quite a lot of multi-sectoral approaches when it comes to NCDs. How are you hoping to improve the outcome for cancer in countries like that?
Well, this is a completely new, unique proposition, and we've heard for many years, and I'm looking around in the audience, and many of us have been in a room like this for the last 7 or 8 years talking about a multi-sectoral approach. And probably 2 years ago, I would never have thought of being on a stage with our colleagues from the pharma industry, colleagues from academia, from the professional cancer organizations, to work with a national and a local government and local civil society on a single ambition to address cancer. That would have been a far-fetched idea. But I think what's happened over the last few years is we've understood that we do need to work collectively, and we've tried ways where we can achieve something. This has emerged, I think, as a topic which we can all sign up to. We know that there's a massive cancer burden in low and middle-income countries. We know it's growing. We know that's not where the resources are. And collectively, we can do it together, but we can't do it individually. The pharma industry cannot solve the problem. The radiotherapy industry cannot solve the problem. Civil society cannot solve the problem. Even WHO cannot. But if we pull those groups together and identify where the gaps are in a city like Asunción, then we can work collectively to address those gaps over time, and with our colleagues from World Bank and others, look at how we can fund that sustainably over a longer period of time rather than being a pilot. This is not a pilot.
And just taking a step back, how does dealing with cancer feed into the Sustainable Development Goal, which of course is looking at all NCDs?
Well, for many of us in this room and around the world, we've actually been working on the 2025 goals. I mean, the 25% reduction in NCD premature deaths by 2025. So the SDG goal, the route to the SDG goal is actually focused on 2025. And within those targets, there were two things. One was that premature deaths for cancer in that time period, focusing on risk factors alone, we don't have a lot of chance of making that happen because the incubation period between giving up tobacco and the chance of getting cancer is so long. However, within those targets, there was the 80% availability of essential medicines and essential technologies in all countries around the world. So if we defined what that was, then the challenge is if we get into cities around the world, look at early detection, and we put in treatment, then the contribution of the cancer community towards those goals, which we believe are fundamentally important for the next generation, can be achieved.
Okay. All right, let's turn our attention to Asunción. And I know that unfortunately the Minister of Health, who was planning to be here, sadly can't be here. So Miguel, I know you've got a message from the Minister of Health, Barrios Fernandez.
Yes.
And this is going to be in Spanish, everybody.
Yes, thank you. Hello. First, let me express how happy we are of being here. Thank you to Access Accelerated and to the UICC for the work you're doing in Asunción. And if you allow me, I'll just step out there and read the message, and then I come back.
Please do, yes.
As we are in the digital age, I'm going to read from my phone.
Very high tech.
We have to think green. This is the message from Mr. Antonio Barrios from the Ministry of Health and Social Welfare of Paraguay to all of you. Distinguidas autoridades, estimados delegados, es para mí un placer dirigirles la palabra. Para la República del Paraguay, La lucha contra el cáncer y las enfermedades no transmisibles es una prioridad ineludible. El gobierno nacional del presidente Horacio Cartes no ahorra esfuerzos para dar visibilidad a esta situación y buscar soluciones para la misma dentro de sus propios recursos presupuestarios, así como a través de la cooperación con los organismos internacionales y el firme compromiso desde y con la sociedad civil. En el Paraguay, el derecho a la salud está protegido a nivel constitucional y nuestro sistema de salud trabaja para atender las necesidades de toda la población sin discriminación de ningún tipo. Esto nos lleva a una demanda creciente y sostenida de más y mejores servicios que requieren, a su vez, una mayor inversión pública año tras año. El nuestro es un país de ingreso medio y sin litoral marítimo, lo que nos pone en una situación compleja en el marco del acceso y cobertura universal a la salud. Nos preocupa el desafío que enfrentamos hoy a causa de la escasez mundial de medicamentos y vacunas. El Paraguay hace esfuerzos titánicos para dotar a su sistema de salud de un esquema de vacunación completo para la población. Trabajamos a fin de que nuestros nacionales acudan a los servicios públicos de salud y para estimular la conciencia pública orientada en la prevención primaria. Un efecto de esta apertura es que en la actualidad soportamos una constante y creciente demanda de medicamentos de alto costo, como son los medicamentos para el cáncer y otros trastornos complejos que resultan inaccesibles tanto para los propios ciudadanos como para el mismo Estado. Esta asamblea, estas personas, juntos deberíamos buscar producir orientaciones y acuerdos para asegurar un acceso equitativo a estos medicamentos con costos que favorezcan las inversiones y que produzcan un impacto en la calidad de vida de los pacientes. Para finalizar, quisiéramos destacar la colaboración con los actores no estatales, con Access Accelerated y UICC particularmente, con quienes seguiremos trabajando para hacer de nuestra capital, Asunción, una ciudad que extiende sus servicios a casi el 20% del total de la población del país, un ejemplo de efectividad de la lucha local contra las enfermedades no transmisibles y particularmente el cáncer, en busca de la realización del ODS 3 y las metas relativas a las enfermedades no transmisibles de aquí a 2025 y a 2030 en los ODS. Muchas gracias. Let me go back there.
Thank you, Miguel. So first, Secretary, as we've said, Asunción is going to be one of the learning cities for the City Cancer Challenge. What are you hoping that will bring to the table?
Well, let me do this part in English.
You can do this part in English, yes.
And, well, yes, for us, it's not a new approach. The multi-stakeholder or multi-sectoral approach is very usual for that sector in particular because it's been a tough burden for us. So what is new, from our point of view, is that this initiative, particularly in Asunción, focusing on the city that has the responsibility to take care of the most part of the population from one city, in particular in Paraguay. So the assembly of people and resources coming from the public sector and the private sector is the new approach, the added value that we need in this part of the.
This is key, isn't it? These partnerships, because one of the issues that Kerry was talking about was that in terms of priority, often other conditions, infectious diseases, for example, are prioritized over NCDs.
It's fundamental. It makes a difference because in a country like ours, even when you as a country comply with every single commitment that you made internationally, still we have seen the double burden. So you have the contagious diseases and the non-transmittable diseases that cause a same burden. So you cannot prioritize from your own point of view as a budgetary previsibility. So the focus of the international cooperation along with the local and national governments is fundamental and it makes a difference.
And Kerry, what lessons are you hoping to learn? I know that it's early days yet, isn't it, in Asunción? Tell us what exactly is happening there.
Well, we launched CCAN 2025 in January in Davos with our partners in the World Economic Forum and the World Bank. We have started in Cali, in Colombia. We had started last week in Asunción, pulling together the local organizations and individuals that the government and the national leadership wanted to pull together. I think what you said is very important there, that the process of evaluation, understanding the assessment where they are and where they could be, is actually driven by the local people with the support and assistance of the international community. And this is quite important because for us, we need a government and a local community that take ownership of the city counter challenge. We don't want to see it as being forced on anyone. We want them to conduct much of the assessment themselves, to identify the gaps themselves, and then the community to coalesce around those challenges so we can address them. So a simple one would be, for example, in a city where there was a lack of pathology, we have the American International Organization to help us to see how we can improve pathology in that particular city. So depending on the city, the nature of the burden, the ambition, the funding, then we should be able to respond to each individual's requirements for the future.
Excellent. And presumably, Miguel, if it all works in Asuncion, it will be rolled out on a wider scale. The kind of lessons that you learn in Asuncion can be applied nationwide.
That is the idea. We take it as a learning process as well in order to expand afterwards. But it's a very important point, the empowerment of the local government in particular and the people itself of the city to take ownership of the process because they are going to show us the way.
Okay, gentlemen, stay with us. So now I'm going to throw it open to you guys in the audience. We've got lovely ladies holding microphones. Who would like to ask a question? Come on, someone has got to start the ball rolling. Okay, gentlemen in the second row.
Good morning. My name is Farid Al-Haffar. I am a program officer in the Program of Action for Cancer Therapy. I work for the International Atomic Energy Agency, and we have a joint program with the WHO. In September 2016, I coordinated an assessment of the capacity and needs in terms of cancer control in Paraguay. This was a joint mission with the WHO, PAHO, and with IARC, the International Agency for Research on Cancer. This was the second assessment in cancer control that we were doing in the country. The first one was in 2010. We provided the Ministry of Health. I had the opportunity to meet with Minister Barrios with a set of recommendations, and we just submitted a very detailed report including all areas of cancer control. That is to say, registry, prevention, early detection, diagnosis, treatment, palliative care, education and training, and civil society. So my question to you is, how do you plan to take stock from the government of Paraguay of these assessments and coordinate with PACT on the follow-up of the impact mission? Thank you.
Yeah, so this is about a comprehensive needs assessment, isn't it?
Let me answer that one, and perhaps you could come in. Sure. You're probably aware the UICC has been our partner through a lot of the PAC missions over many, many years, and I think the Ministers of Health have appreciated the detail with which those country missions have actually taken place. The output of those missions have been with the Ministers of Health for them to take responsibility on how they're taking things forward. It would be very helpful, I'd say very helpful, if the Minister was able to share some of those conclusions with us that we could fold into this work. Now, I will stress the PAC missions are quite comprehensive. As you said, you did cover the preventions, the registries, etc., and that's absolutely fundamental. And I don't want anyone to come away from this meeting to think that UICC does not fully appreciate the need for a cancer control plan, for registries, for prevention, risk factors, working with the NCD communities. Absolutely no way. What we're doing is we're bringing a community together to tackle one end of that spectrum, and that is about treatment and care and then folding into early detection. So that's where we want to spend our time. This is where we have the global expertise aligned in that space. So my plea would be to any of the PAC mission countries where there are recommendations coming out of those PAC missions that we fold them directly into this work. No, we certainly don't want to replace anything. Knowledge itself is rare in our space, and the more we share it, the more we can do with it. So I would love to see that information presented, and we can work with the health minister, who I'm sure would want to include that anyway in the work that we're doing.
Excellent. Miguel, do you want to add something to that?
Yes, please. As there was mentioned about the mission of Paraguay, in Paraguay, yes, we are certainly aware of that mission. I'm very happy that took place. And let me switch here to Spanish just to make you work a bit, so you don't have some free time. La misión para nosotros dejó una base de información muy importante, que efectivamente me hubiera encantado que el ministro esté aquí para contarte esto porque él tiene un conocimiento muy profundo. Pero tuve la oportunidad de hablar con él en asambleas pasadas y te podemos decir que la información ya corrió por todos los estamentos de Estado, incluso la Cancillería tiene información sobre las recomendaciones que recibimos por la misión. Y para nosotros juega un rol muy importante por dos cosas. Porque el cumplimiento de los compromisos es un esfuerzo el total del Estado paraguayo, no solamente del Ministerio de Salud. Porque combatir las enfermedades incluye también elementos de sociedad, como la pobreza, dentro del sistema de salud nacional. Y además, porque nos permite tener un mayor conocimiento para conseguir aplicar a nivel local el cumplimiento de los ODS, que siempre tiene una dificultad en la traducción de los indicadores globales a la aplicación de los indicadores nacionales. Así que mucho agradecemos la misión y vamos a seguir trabajando junto con la IAEA y con la OMS. Gracias.
Okay, thank you. Thank you for your question. Any other questions? Gentleman in the first row here.
Hi, good afternoon. John Zaracostas. I'm a correspondent here for various publications in medical and general areas. My question is, I would like first to ask the gentleman from Paraguay, what is roughly the average cost of drugs to treat lung cancer and prostate cancer in Paraguay? And secondly, to Mr. Kerry, your program is aiming to reach how many urban centers or cities in Africa, where I understand oncology is provided in, oncology capacity is only provided in a handful of countries. Thank you.
Okay, so a very specific question about the cost of drugs to treat lung cancer and prostate cancer. Do you have those figures to hand?
I don't have the actual prices. What I can tell you is that for the patient and for this welfare system, it's very expensive, even more than normally within 30 or 40% more than other countries, because we have a limited access to the international market in order to buy the medication for those particular situations.
And secondly, Kerry, we said 200 cities were going to be in the first wave of the CCAN 2025. How many in Africa, urban places?
Let me just correct the 200 number, okay, because it's not quite 200. So there are 520 cities over 1 million,
Right.
and there are about 300 that are in low middle income countries. Our long-term ambition is that every city, whether you're a Boston, a Washington, or an Asunción, or a Cali, or a Yangon, should, over a period of 20, 30 years, should be able to report that they can deal with the cancer burden they're facing. Now, is that possible? Yes, it is. If you go to Jordan and you look at the history of Amman and the King Hussein Cancer Center, you will see an exemplar of what can be achieved in a 10 to 15-year period. So we know it's possible. Our ambition in the first 3 years is to have 5 learning cities from around the world. We will be announcing a city which will come as a learning city from Africa in the next couple of months, possibly in November in Mexico at the World Cancer Leaders Summit. It may be slightly before then. And we're currently in discussion with another city in Asia. But the learning cities are what they're described to be. They're learning cities.
But the question was specifically about Africa.
In Africa, we will have, I will probably imagine, by the end of next year, we will have 1 learning city, and there's a possibility that 2 cities might sign up to do the process themselves. But I don't know if they're going to do that. I can't guarantee it. But I can give you the long-term ambition and the route that we're going through that. I can't tell you how many cities will sign up themselves. They would need to make commitments themselves and agree to engage with the international community to do that. But let me give you an idea of sizing overall. It could be 50 cities within 3 years around all the regions, and therefore one would assume, say, 5 cities in the African region may sign up themselves.
Okay. Right, I think we're going to leave it there for that session. And big thank you to my guests, Miguel Candia and Kerry Adams. And we will invite the next 2 panelists to the stage. Thank you, gentlemen.
Thank you very much.
So the next session is looking at how Access Accelerated is partnering with the World Bank Group with several country pilots which are going to be announced for looking at integrated NCD care. And I'm pleased to invite Dr. Tim Evans, who's the Senior Director of Health, Nutrition and Population at the World Bank Group. Take a seat. And this one next to me, not the far one. Lovely. Thank you very much. Good to have you with us here on stage. So, we know that the World Bank is pioneering with Access Accelerated, conducting pilots in several countries to improve NCD care. Can you give us more details about that?
Yeah, well, I think this is part of our effort to move health systems much more quickly towards the SDG target 3.8, which is universal health coverage. And clearly, NCDs are a critical part of the burden of disease in every country. And when we look at challenges to achieving universal health coverage, we find that globally over 400 million people lack access to essential interventions. And a large proportion of those interventions are for effective treatment of non-communicable diseases, often at a stage either in primary or secondary prevention when it makes much more sense to intervene on NCDs rather than waiting for end organ complication, which requires high-cost hospital-based care. So there's a huge agenda around service delivery. But as a bank, you'll not be surprised that we're very interested in financing, and we really have a very serious problem when it comes to financing health systems in most countries, because still in this day and age, most systems in low-income countries are pay-as-you-go. And the primary manifestation of a pay-as-you-go system is that people pay out of pocket when they're ill. Now, all of the best evidence in the world, including from the World Health Organization, suggests that's the most inefficient and inequitable way of financing a health system. You have very few people who access care. Those who do access, who have trouble, access too late. And so systems tend to cater towards those who have the money and end up being very inequitable. Every system that has moved towards universal health coverage, including my own, I'm a Canadian, there was initially great resistance from doctors who thought that they would lose out in 1962 when Canada decided to move towards a universal system. And it started in the farming provinces of the prairies, Saskatchewan, where the premier of that province said, you know, it's just not right that a farmer should lose the farm when he falls ill. And so they instituted a system where everybody had access to care. And lo and behold, a year later, the doctors realized they were going to be better off if 100% of the population had access to care and not just 10% or 15%. So on the financing front, we have a huge agenda which is not specific to NCDs, but if we move systems from pay-as-you-go to prepayment and pooling, to insurance-based or tax-based systems,
So
then
these are the kind of innovative financing issues that you're looking at, new ways of bringing
that's
money
right,
to the
and there are
table.
new ways because in a lot of low-income countries you can't rely on the tax base exclusively, nor can you rely, as you do in Europe, on the employers. There simply isn't enough formal employment. So we have to be much more innovative with respect to how we pool those resources from the very large informal sector. And there are some very interesting mechanisms which are looking at how on the back of mobile banking platforms you can actually get contributions for healthcare which are much more sustainable using 21st century behavioral economics where people don't opt out as opposed to having to opt in, which then sustains contributions from the informal sector. So these are amongst some of the things that are going to allow us to move forward. But it's also some well-proven things. Sin taxes on tobacco. it's a no-brainer. If you look at the number of countries that are compliant with the Framework Convention on Tobacco Control, there's still a tremendous amount of room to go. And the reason this is important is because it's a public health good, but it's also a health financing good.
Yeah,
so you
I
raise more.
I love that term, sin taxes, and that's clearly designed to have a preventative role in mind as well.
That's right. But it's a great win-win, but as one of the great health economists, Reinhardt, says, sin taxes are great, there just aren't enough sinners. So you really need to recognize that they're a critical complement to financing, but there are also ways in thinking about taxing other bads or giving incentives to some of the public health goods, which are part and parcel of moving us in a primary prevention much more effectively.
Well, I hope they never tax chocolate. Sin taxes on
That's right.
chocolate, I would be totally financing your entire project there.
That's right.
How crucial is collaboration with the private sector in all this?
Absolutely fundamental. We have a problem in that we have the most inefficient form of private sector financing as the majority form of financing at the moment. People are paying as they go. So number one, we've got to figure out how to get individual private contributions into a way that we can pool, strategically allocate, make NCDs a priority so that systems can really support and walk the talk with best practice and guidelines. Number one. Number two, it's really interesting. In health, we have a bevy of the most cost-effective interventions in the world that will improve and take care of this agenda. And so it's not the absence of drugs or good interventions, it's actually the absence of good delivery systems. And so if we look at how we can strengthen those systems from the front lines as the first priority, then I think what we're going to see is levels of effective coverage for things like hypertension and basic screening for cancer are going to go from, 10 to 20% to 80 to 90%. And that's really our challenge in the next 13 years that we have in the context of the SDGs.
One of the questions raised by the audience in the previous session was how you assess exactly what's available, what can be done, and take stock. How are these initiatives going to be used to rigorously monitor and assess results and see what works?
Well, there are a couple of things, and there's tremendous innovative potential in delivery systems at the moment. Big data, digital delivery systems, and even drones are being used to sort of decrease time and space with respect to delivery of essential commodities. But part of that is that we need to change the culture in health from one of to portfolios, right? A little project in one place just doesn't scale, right? So how do we think about disruptive innovation at scale? How can we think if something works in one country well, having dozens of countries learn about that innovation and adapt it to their own context quickly so that they're not reinventing wheels. So one of our roles is to really try and look and see how we can source, scale, and share those innovations so that countries are much more likely to pick up these innovations in service delivery, which are really going to effectively deliver the promise of universal health coverage.
Okay, any questions from the audience? Gentleman at the end of the back row there.
Thank you, Tim. The question relates to your comment about the innovations and to scale them. How do you see the role of the World Bank to reduce the risk aversion of policymakers to this type of innovations to scale them up? Because I think one of the factors that prevents them is the risk. Will this work? What will happen if they wouldn't? But in that perspective, I guess the World Bank can play an important role to embolden them and also somehow reduce the risk they may face? And would that entail somewhat more of the risk-taking approach in the World Bank to this type of the projects that really need to go beyond the box and try something really innovative that hasn't been tried before?
Yeah.
That's a great question.
Great question. So, I think, let me start by saying, when you work in a big bureaucracy, one of the things that keeps me up at night is that we're not sufficiently sensitive to new ways of doing business. And that's because, by definition, over time, you have all sorts of bells and whistles, checks and balances, which relate to keeping your system on track. The cost of that sometimes is that you're not sufficiently sensitive to new, innovative ideas. So this is something where we as an institution are looking particularly towards the private sector or non-state providers, where often you see innovation taking place. And our role is not to be the innovator per se, it's really to say, how do we identify what constitutes a true innovation, and how can we help integrate that in such a way that it doesn't remain a pilot, but actually achieves the system-wide scale opportunity. And so let me translate that much more tangibly. If, for example, we find there are ways of empowering community health workers to provide primary and secondary prevention for NCDs, and there's some effort which has piloted something in one district of one country, we're very interested. But the knowledge and implementation know-how challenge is, how do you get that across 47 counties? And then, if it really is that good in one country, why isn't it that a dozen other countries in similar contexts with similar challenges are not also adopting it? And so our effort and energies really are looking at, how do we get these things to scale in a sustainable way? We have all sorts of innovations, sometimes so many that people refer to them as pilotitis. And I think WHO has put this into the new International Classification of Diseases. So we've really got to look at how we change that culture and go from startups to scale-ups.
I mean, this idea of taking risks, it's a good point, because when you look at the economic burden that NCDs have on a country, why aren't governments and policy makers and decision makers more willing to think outside the box?
Well, it's interesting. I'm impressed by the innovation I see. In this room this morning, or somewhere in this hotel this morning, perhaps one of the most innovative, creative ministers of health, Recep Akdag from Turkey, was telling us about his second generation reforms. But he was basically somebody who was interested in innovation and scale. And so in the health transformation program in Turkey, they had this problem of very poor access to essential medicines for the majority of the population. And so they worked with the pharmaceutical industry and shifted the market from low volume, high margins to high volume, low margins. And it was a win-win. The country now has a universal system. It's growing rapidly. It's got front lines and continuity of care. That leadership, I find, is not absent when you have a discussion about how to go to scale. The other part of this that I think is extremely important, and why politicians are increasingly sensitive, is that people and populations are not sitting back idle. If you look at the growth in expectations that are prevalent in terms of what people's care and access to care should be, if you look at the drivers of the need for care related to both aging populations and an understanding of what's possible through technology and good drugs, then we're seeing a lot of very encouraging action whereby patients and citizens are being engaged both in the co-design and co-delivery of their care. And so I think this is a very, very positive sense. Last thing I'd say, when you put the value for money proposition to ministers of finance, they get it. If you have a system that's smart and delivering good value for money and is achieving results, diminishing levels of chronic morbidity and disability and improving survival, then that is not only good for your health, it grows your economy and,
Sure.
it enhances your competitiveness in the 21st century global economy. We just finished a huge study in China, which was driven by the president and the premier, who said, if we don't move our systems to more effective universal primary care, we will not be competitive in the global economy in the next 20 years.
Okay. All right, another question from the floor. Anyone have a question about how we're going to resource? Oh, there's
Gallants.
someone at the back there.
Gallants.
Behind you.
I'm here.
Microphone.
Okay.
Oh, yeah. Lovely, thank you.
Garen Sepham from the World Alliance Against Antibiotic Resistance. Of course, that's a transmissible disease, but since we know that cancer therapy needs antibiotics, there's a link there. I like very much what you just discussed, because I remember Jim Kim, the head of the World Bank, soon after he was nominated, he published an editorial in The Lancet, which was about new systems of delivery, which I thought was tremendous. But then I waited, and didn't see something very tangible coming out of the bank. So we hope for you, because, for example, one thing that hasn't been mentioned is the problem of migration of doctors coming to work in the UK or in the US or in France, because they don't have good wages and good working conditions in their countries. If we had set up schools in which people would be trained in new modern ambulatory technology, in creating a new system, in young doctors in Africa going into the countryside to deliver care with fancy vehicles, fancy diagnostic tools, seems to me that there would be a lot more enthusiasm.
Okay, let me put that, because
the
I think...
migration problem, just one last point, is also the problem. I've worked in Africa in the past. We have the problem of people wanting to stay in the cities and not going to the countryside. But if we set up a very modern system, diagnostic at a distance, and use all the new technologies, we could have a tremendous efficiency. And one last point.
No, thank you. We are running out of time, but thank you for the point. And what I'd like to turn that into is excellent points made by the lady there, but starting out by saying we've heard promises like this before. We've been promised delivery systems that are more efficient, and yet they never materialize. So what's going to be different now?
Well, I'm a little bit more glass half full. I see just tremendous innovation, especially when we think about the whole system. And when I say the whole system, it's including the private sector. Just take Garence's point on the health workforce. There's a massive market in training of health workers. And we know the demographics globally with aging populations and increasing dependency ratios in OECD countries. There will be a huge magnet effect for high-skilled and long-term care workers in OECD countries. We know that now. There's no reason why countries shouldn't be preparing, recognizing that some fraction, significant fraction of their workforce will migrate. That doesn't, and that is by no means incompatible with thinking about resilient systems for ensuring that every village, every community has a health worker. Decentralizing training, drawing people from the communities where they've grown up, giving them appropriate skills, giving them career structures, a little bit like Ethiopia and the new Director General have done with community health extension workers. Those are massive opportunities for innovation in the way we think about training and deployment of the health workforce. And if you think about it from a Ministers of Finance perspective, this is a sector where the employment share grows faster than other sectors. So in OECD countries, over the last 15 years, what we've seen is that the health sector employment has grown as a share of total employment faster than other sectors. So if I'm interested in employment, which of course I am if I'm a Minister of Finance or a head of state, I don't see the health sector as a black hole and a waste of money. I see it as a sector where there's a virtuous cycle between better health, better growth, and better employment. So yes, one can say, yes, there's a big agenda to go, but if you look at the opportunity and the rate of growth of health systems and the plurality of actors that are engaged in different ways in different parts of the value chain, the health workforce, the information sector, the pharmaceutical sector, we've never had greater opportunity. So I'm very optimistic, but I have to say, and this is why we talk about accelerated access, if we're going to be where we want to be by 2030, we don't have a lot of time. And so I think what we really have to do is think about how to empower countries much more effectively, use our development assistance in such a way that we're empowering those countries and those leaders to make the right decisions, such their systems not only achieve those results by 2030, but sustain them moving forward.
Tim, thank you very much indeed for that. Dr. Tim Evans there from the World Bank Group. Thank you.
Cheers.
Excellent. Now we'll get the final lightning session, the role of public-private partnerships to advance the SDGs. I'd like to invite to the stage Anne Arts, the head of Novartis Foundation, and Katie Dane, the executive director of NCD Alliance. Ladies, welcome. Good to have you with me here on the stage. Anne, let me start with you, because I know that the Novartis Foundation has launched an initiative to tackle hypertension and its root causes. Better Hearts, Better Cities. Tell us about that.
In fact, we announced it last week. We launched Better Hearts, Better Cities to improve cardiovascular health in urban, low-income settings. And specifically, I say cardiovascular health because it's not only about the healthcare. We want to address all the underlying determinants of cardiovascular health as well. As you know, the healthcare systems alone can only solve so much of the problem, but the main part of the solution and the impact you can have on cardiovascular health is when you work on the food, on the exercise, the tobacco, the alcohol, the pollution. So we want to work together with different sectors and different disciplines to bundle resources, to bundle expertise specifically, to find new solutions to address the enormous burden of hypertension and cardiovascular disease in cities. Hypertension, in fact, high blood pressure, is the #1 risk factor for cardiovascular disease and is killing like 10 million people a year, which is as many as all infectious diseases combined. So the burden is enormous and is too big for one actor alone to address.
Right, so you're taking a multi-sectoral approach. How important is the PPP model here, the public-private partnership? What kind of partners are you looking at?
Well, it's a new initiative. It's similar to CCAN, but we try to bundle the resources and expertise of different private partners. So we look at the partners from the food sector, from the transport sector, the digital sector, the energy sector, urban planners, academics, and the government. The condition for starting this initiative is that there is local ownership, as was mentioned by our previous panelist. You need to have the local government in the driving seat. They are co-developing this with the private sectors around the table. But of course, we can work on what is needed in the healthcare and the service delivery innovation side, but we cannot work on making choices healthier for the populations living in slums, for example. For that, we need thought partners and other resources to think about how are we going to make healthy food oases available in a city like Ulaanbaatar in Mongolia, where it's -40 and you never have fresh fruits or vegetables for 9 months a year. How on earth can you preach for better lifestyle if you don't have healthy choices? So we need these partners around the table to help us design these innovative solutions.
Katie, let me ask you, because obviously the adoption of the Sustainable Development Goals have an impact on NCD prevention. What does that mean for that and for partnerships?
To answer that, you really need to think about what's really in it in terms of the Sustainable Development Goals, because it's a fundamentally different agenda from what we have been used to over the last 15 years. It's a 17 goal, 169 targets, and however many thousands of indicators that are behind it. But what's really important is that the SDGs are for all people, not just for a few, whether age, sex, race, religion, it's for everybody. So we're leaving no one behind is the real mantra within it. It's also for all countries. It's not just for a few, no longer just a low middle income country agenda. It's for every single country of the world. It's also about not just about now, but it's also about the next generation. So it's really the sustainability of it is really key. And obviously the most important thing from our perspective is obviously that NCDs are actually in the agenda, which they weren't in the previous agenda for the Millennium Development Goals. So it means that, and the other important point in terms of the SDGs is, as Tim mentioned earlier, I mean, this is also an agenda which has really encompassed universal health coverage for the first time. And that demands us to not just work in our little silos that we're all very comfortable working in, but actually looking beyond. So in terms of partnerships, I think it means from an NCD perspective that first and foremost, we need to be looking at partnerships that are actually addressing the real challenges and need. Rather than just thinking about our own interests and needs, they need to be really honing in on the real issues on the ground that we're seeing. Secondly, it means that we need to be breaking down the silos, connecting the dots between NCDs, between gender, between the environment, between the economy, really working across sectors, which is much easier said than done. And then finally, we need to be looking at partnerships that are both sustainable and scalable, but also that we're thinking very carefully from the very beginning about the metrics for impact, because so often public-private partnerships are set up, but actually trying to learn the successes and the challenges of them. Everyone's very good at talking about the successes of things. It's a lot harder to actually say, hang on a sec, this really didn't work for us. That's really what's going to move partnerships forward for NCDs.
I expect this is the same for the Better Hearts, Better Cities initiative as well.
Absolutely.
That there is, we've talked a lot about government involvement, department involvement, organisational involvement, but there has to also be a meaningful involvement of people living with NCDs.
Absolutely.
Exactly, and this is something that we're, as NCD Alliance, really focusing on. I mean, we've obviously got the 2018 UN high-level meeting on NCDs next year. We've gone through 2 high-level meetings in the past, 2011, 2014. Those were really important moments from a political perspective, but what they didn't do was really raise the voice of people living with NCDs in the response, which is what we really want to see a lot more. And when we're talking about meaningful engagement and empowerment of people living with NCDs, we're meaning from the individual level, people living with NCDs front and center of their care and support that they need and require. It's also about involvement in terms of policy and governance. So when governments are consulting on policy, whether it be around prevention, treatment care, palliative care, it's always got to involve people living with NCDs, because at the end of the day, they are the experts in this field. They know the best about what they need and what services they require. And then also in terms of empowerment, we know from many other communities, and I kind of avoid comparing us to the HIV/AIDS community in many ways because we are so fundamentally different. But there are a couple of examples that we obviously can learn from, and that is having champions, having people living with NCDs being advocates. And what we need to see a lot more of is that in every single panel at the World Health Assembly, we have person living with or those affected talking about their experience, because it really hits at the heart of policymakers.
And that's one of the issues that you're looking at in terms of care for people with NCDs, but also preventative measures which need to be put in place.
Yes, absolutely. You have to have the patient and his family and community at the center of the whole design of the intervention. Of course, we want this initiative to be a global initiative, and we've selected 3 cities, one in Latin America, one in Africa, one in Asia, for demonstration countries, similar to CCAN, where we learn from. And within those countries, we co-design the interventions with the patients, with the civil society, with the health authorities, and the different private partners or other public partners, like the education sector. We get around the table. And I think Katie's point on showing that it works is super important. You have to measure what is going on. In fact, we come from the Novartis Foundation is coming from an evidence-based company, so we measure everything we do, and you have to also have a measurement that is shared across the partners, that everybody is well aware of what is happening and what works and what doesn't, but is also held accountable for what he or she has engaged to do. So the shared measurement system is absolutely key. Next to the common goal of a partnership, you have to demonstrate that it works. And there come the academics come into the game as well.
And that is one of the crucial questions of using the PPP model, isn't it, Katie?
Yes.
That we have to determine what makes for successful partnerships and what can be scaled up into an effective system.
Yeah, absolutely. I mean, you need to understand from the beginning of any public-private partnership, you know, what's your mutuality of interest, what's your specificity of purpose, and then also what are your metrics for success. Unless you've got those three ingredients, public-private partnerships are not going to go
and
anywhere.
making sure that the private sector lives up to the pledges and the promises that they've made as well. That these are tangible things that are being brought to the table and not just empty promises.
And that's where civil society can really come in as well. I mean, you know, we're obviously play an important role in accountability of government progress, which is why the 2018 high-level meeting next year is so important. But also we play a role in terms of, you know, tracking progress of the private sector as well, which is critical.
Excellent. Ladies, just stay there. Are there any questions from the audience? Lady in the 1, 2, 3, third row back. With the lovely scarf on. Yeah.
Thank you very much. I am from UNICEF, and I would like to congratulate the panelists, also those who spoke earlier. And we know that for children and through the life cycle, so from prematurity to also adolescence and on, NCDs are critical for their survival, but also for their well-being. And again, from prematurity to mental health, substance abuse, and road traffic accidents, and universal health care. Maybe I would like to know a bit more what you are doing on the prevention side. How do you engage younger generations? I mean, also looking forward for the SDGs, we are asked to engage, to work with younger people. Any plan or any strategy to partner also with them? Thank you.
Yeah, that's an initial. It's age-specific and gender-specific. Is it just to lead on from that as well? So how is that being handled?
Sure. So I mean, in the NCD space, like many others, we always throw around the phrases life course approach, and I think in NCDs it's absolutely crucial. You've got to start, you know, early childhood development, increasingly, you know, really focusing on adolescent health, because that's obviously really the formative years when so many people are actually beginning to develop their behaviours for the rest of their life. You can really have a window of opportunity to influence behaviours in future life within adolescent health. And then you've obviously got the 30 to 70 age bracket, and then the elderly population as well. So we've really got to be looking across the life course. And you know, from the NCD Alliance's perspective, what we've been working on with many other partners, such as NCD Child, amongst others, is trying to get the early childhood development community much more engaged in NCDs. And UNICEF is one of the key partners that we're keen to work with, because what we know is that whilst the World Health Organization is a key agency for NCDs, obviously, we need to be seeing all of the different UN agencies really taking much more of a leadership role in NCDs. And that's beginning to happen, but we need to see a lot more of it, I think.
Anne?
Yeah, if I may add something, I really want to thank you for the question, because it's true that in the NCD world, we tend to think it's a disease of the elderly or the aging population, and we forget the children. But for example, one of the innovative programs or incubator models, as we call them, which are smaller projects, where the Better Hearts, Better Cities is an initiative, we aim for sustainability at scale. One of them is really working with schools in South Africa. And we see that the problem of high blood pressure is already present in children under 16, children living in very underserved areas and very unsecure slum living conditions have a very high level of stress, but there may be a lot of other factors. And they are already very much affected by the disease, not only because of their living conditions, but also because of the possibility to be born with a low birth weight prematurely. Everything is increasing your risk on NCDs, and I think it is crucial we start with the schools, with the as early as possible working on chronic diseases, not only prevention, but really making everybody aware this can be a problem of early childhood already. I think it's a very essential point.
Yeah, great question. Thank you very much indeed for that. Any other questions? Lady at the back there.
Hello, my name is Florence Gardery Perkins with Digital Health Partnerships, and it has struck me all week, all the NCD events, and we are talking about innovation at large, but not much reference is being made to digital health in general. I was very glad to hear Tim Evans make a mention of the importance of, for example, the mobile banking model for universal health coverage, because I really believe the mobile health insurance innovations are showing unbelievable promise for that. But more importantly, I've always believed that digital health can have a huge impact, in particular on NCDs, because as we all know, prevention is huge. Of course, the digital health in general has a huge potential, powerful tool for access in general. So my question is, why are we not hearing more of this? Clearly, awareness still needs to be raised on the power of this tool. And I think to the point that Tim Evans made, what can we think of in respect to some sort of system that would help sort of cross-fertilize? Because the innovation is there and the technology exists, yet the awareness level seems to be low, as represented, I think, by some of the conversations I've been hearing this week. Thank you very much.
Thank you very much. Anna, isn't that something that is happening with Better Hearts, Better Cities, actually, the digital and communications technology?
Yes, absolutely. We are big fans and big passionate about digital health, and not only on the programmatic level, but also on the policy level. And thanks for that question, Florence. But digital is really key of the a key means not to get to the innovation of health service delivery. The potential is huge. You can expand access to care, you can increase quality of care, centralize expertise, coach community health workers by phone. We have models of all these things that work well, and you increase better your surveillance, and your action is oriented to the real needs if you use that surveillance. So there's a lot of potential in digital health. The problem we see on the ground is that you have all these wonderfully well-intended solutions addressing very often one single problem, like an HIV adherence tool, a TB adherence tool, and nothing can be coordinated anymore. So our call with our report that we recently launched for the Broadband Commission for Sustainable Development is a call for leadership in digital health. And leadership means that the government has to have the vision that they want to integrate digital into their health system so that it can really respond to the priority health needs of a country. For that, you need the Minister of Health or the Minister of ICT and all of them together to work together and make that happen, that it becomes a national digital health strategy. And only in that way can you realize its full potential. But it means digital is really essential if you want to have an empowerment of the patient, link him to all the levels of providers when they need, link the different providers with each other, and then make it a coherent, coordinated pathway for patients. And this is very well possible in low and middle income countries where there is not 100,000 electronic hospital or health records like we have in the US or in Europe. You really can start from the beginning. Then this national digital plans is the best way forward.
And is that something NCD Alliance is looking at as well, digital health?
Absolutely, yeah. So NCD Alliance joined forces with the initiative called Be Healthy, Be Mobile a few years ago, which is an initiative of WHO and ITU, together with civil society organisations, pharmaceutical companies and telecommunication companies. And it focuses on various different things, such as diabetes, cessation, hypertension, working very much with governments at the country level. And it's proven to be really effective, but also the impact on the ground that it's having as well.
Okay, one more quick question. Lady at the back there with the sunglasses on her head. Yes. Thank you.
Hello. Yes, thank you so much for your interesting presentations. And it's really great to see Novartis taking a strong leadership position in prevention, especially from a private foundation point of view. So I was wondering, would you be able to take that private leadership further and actually reach across the table, as you're so keen on prevention, to companies which are actually preventing prevention? So I'm thinking about the food and beverage industry, I'm thinking about the alcohol industry and tobacco industry. It would be great to see private leadership, as you seem to be so keen on prevention, to really, is that something you could do to reach across to your fellow private members and suggest that they also incorporate?
So you're suggesting sort of partnerships, like for example the sugar industry, canned drinks, so those kind of companies that
I'm not sure I'd phrase it as partnerships. I'd say
arguably-
if they're so keen on leadership, it'd be great for them to lead in their own private fields and suggest that they take on prevention for companies who don't seem to be really prioritizing that right now.
Well, that's exactly what we are doing with the Better Hearts, Better Cities. We reach out to the food companies and other sectors to really work together on this prevention. But let me assure you that we also are very much engaged in the healthcare delivery part. The innovation of healthcare delivery has been our focus area for all the past years, for the past 5 years, I would say. But at this stage, we come out of this idea that you can have funding, you cannot continue funding projects that can become very successful and scaled nationwide. You need to be able to scale them to 65 countries, as Tim was saying. You need to make it in a different way, in a way that can become sustainable at scale, not after 5 years, because that's the time it takes for a project to scale, but immediately. And that's why we now sit together specifically, first of all, with the local governments, but also with these private sector partners, the ones you were naming, to make that happen at scale. Private sector is by definition at scale.
But just very quickly, because we are running out of time, is there resistance from certain industries to doing more to tackle NCDs? Because we know what the causation factors are, and some industries might not want to scale down on activities because...
Yeah, I mean, I think we've heard repeatedly over this week that, you know, the private sector is not one homogenous block.
Sure.
There's many different types of sectors in there, and healthcare industry is one, food and beverage industry is another, tobacco industry is completely out there on, completely out of the picture. But, you know, one thing that actually all in the healthcare industry is actually doing a lot of work on, which is a shared interest of Anne and mine as well, is actually the importance of workplace health and workplace wellness. And, you know, all industries can do that in terms of improving the health of their populations, because we know that NCDs are impacting upon people in the most productive years, and particularly that's even younger in low middle income countries. So, you know, the importance of workplace health and the models that are working within that regard are really important.
Okay. Ladies, thank you very much indeed for that. Anne Arts and Katie Dane, thank you.
Thank you.
And I want to thank the audience for some really insightful questions there. Very interesting. Thank you very much indeed for that. We're going to bring the session to the close with some closing remarks from the Director General of the IFPMA, Thomas Kumi.
Very much for an excellent session. Thanks a lot to the distinguished panelists. Thanks to Julie for moderating. All of you who have come here. Listening to the debate, I was thinking how healthy it was for me to move to Geneva, because this is a city where traffic is so slow that the only way to get from my flat to the Schmedemin at the biocampus, and the fastest one, is to walk. And with my iPhone tracker, of course, check how many miles per day I walked. It's very healthy. The research pharmaceutical industry, I think, has long realized that innovation in health and health systems can no longer place in silos. And I think we have heard many times during the course of this week how we really have to break out of the silos. And that's why I was so pleased to listen to the panelists today, how important it is to work together, to share knowledge, to share expertise, and to look for more creativeness in terms of innovation, not just in therapeutic innovation, but also in delivery systems, as was said. Partnership is openly recognized and encouraged in the UN SDGs, and partnership, I think, is very much embraced in our session here. And world leaders and the UN General Assembly have more than once emphasized the important role of the private sector, the important role the private sector has in achieving the Sustainable Development Goals. And I think the pharmaceutical industry, which I heard this morning at an earlier session, starting at the uncivilized hour of 7 a.m., is an industry which is acceptable but under special scrutiny. Now, special scrutiny means that we have to live up to our promises, we have to live up to our pledges, and that we also have to be aware that conflict of interest requires transparency, and that's why the FENSA framework is something which I think we can use. We have over 300 partnerships at present as pharmaceutical industry, and we also, beyond Access Accelerated, which we talked about today, we also last week announced the AMR Alliance, where we have more than 100 partners, not just from what you would expect from me, big research-based pharma companies, but also generic companies, including some from India, biotech companies and diagnostic companies. We have been hearing today about the opportunities under Access Accelerated for the industry to partner with others, with an aim to reach many more patients. I think the notion of scaling up, the notion of we have to start somewhere. I had a visit from somebody from an other industry earlier this year, and they said, we are not really believing in the sustainability of this. Therefore, pilots we are not that keen on. And I said, somewhere between, doing a pilot and reaching for the moon immediately, you have to do some testing so that you can scale up. And I do believe that we are expected, and Carrie mentioned it with the announcement of the 3 learning cancer cities, the aim is to go to much more. I think it is an exciting initiative, and we are confident it will develop and grow into a major access initiative. One of the elements which hasn't been mentioned yet, we have had individual company initiative, and I'll just mention a few new ones to close. We didn't have an initiative where you have 23 companies coming together. And from the discussions I had with our partners, I know that the fact that you now have 23 coming together will allow us to talk about SOPs. What is it you have to respect in terms of appropriate use, in terms of rational use, in terms of also embracing the rationality of an essential medicines list? If you have 23 companies, and hopefully in a year's time we may have a few more, we are ambitious, we also may have a few more partners because we need to connect the dots, I think that is really a game changer. And I wholeheartedly agree with Katie on the importance of being measured. Measured means that you want to drive quality, because publishing data is important. That's why one partner which hasn't been mentioned yet in our initiative is Boston University. And us picking Boston University means that we are not going for the easy solution. We really want to be measured, and measured means unless we can show progress over time, we will have failed. I'm confident that we will be able to show progress, hopefully already in January 2018, because we announced the initiative in January in Davos, but also by having many more individual company initiatives. Even over the last few months, in addition to everything which already happens, we had, for instance, the BMS Foundation, the Support for Global Hope, to provide pediatric oncology training and services in Botswana, Malawi, and Uganda. Africa was mentioned earlier. The MSD Merck Foundation providing support for Project ECHO to provide training to healthcare professionals in Vietnam and India. Pfizer's partnership with Population Survey International to support treatment of hypertension in Vietnam and Myanmar, and the Novartis Foundation, which we just talked about. I know from our conversations with companies, I would expect at least 15 more initiatives announced before the end of the year. We do hope to reach out to more partners. We welcome your critical following us. We welcome partnership with more of you, but I'm confident that together we will make a difference. Thanks for having come here.